Hi students, and welcome to Module 5 of N366, Adult Health 2. Today we are going to talk about lots of different renals and urologic problems, but first we're going to start with Chapter 45. So this first condition we're going to talk about is one of the most common conditions we see, which is urinary tract infection. And this is if you're outpatient or inpatient, you'll see this. It is the most common infection and is the second most common bacterial disease in women. The most common culprits are E. coli or Candida. Fungal and parasitic is not as common. So the urinary tract above the urethra is normally sterile. Our defense mechanisms are to completely empty when we void. That uretero-vesical junction competence helps. The peristalsis, which makes in the ureter, which makes the urine go towards the bladder, helps. Having an acidic pH below 6, high urea, and then glycoproteins that inhibit bacterial growth. Some risk factors of getting a UTI would be obstruction, retention, if there's renal impairment, foreign bodies, anatomic factors, compromised immune response, functional disorders, and then other factors. So it's organisms for the perineum ascend in the urethra. So that's one. The GI tract with gram-negative bacilli. Some contributing factors would be urologic instrumentation and sexual intercourse. Hematogenous transmissions. UTIs are the most common healthcare associated infection. It could be from a CAUTI. We all hear about CAUTI now, right? Catheter associated urinary tract infections. It's a big deal. E. coli or Pseudomonas. This increases the length of stay, cost, morbidity, and mortality. And there's issues with Medicare that, they're not going to be too happy if a patient goes in the hospital and they have to stay longer because of a CAUTI. So now hospitals have implemented quite a few prevention strategies to not have patients develop a CAUTI while they're in the hospital. So what are we going to see? So when we see clinical manifestations, that's when you think of cues. What are the cues that you are going to see your patients or that they're going to complain of when they come in? So for a lower urinary tract symptom, you're going to see emptying symptoms. They're going to say, I feel like I have to pee, I sit down, I can't really pee. Or it's intermittent, or post-void dribbling, urinary retention, or incomplete emptying. I never feel like my bladder's all the way empty. There could be storage symptoms with urinary frequency, urgency, incontinence, nocturia, and enuresis at night. Hematuria or cloudy appearance, so blood or cloudy, the urine should be clear. Many problems produce a lower urinary tract infection, and it can often be confused with an upper urinary tract infection. So upper urinary tract infection could cause flank pain, chills, and fever. This could be pretty dangerous. Could also cause fatigue, anorexia, or could be asymptomatic. Older adults, the classic manifestations are absent. Often you'll see older adults like they're acting funny, and sometimes if they just all of a sudden have a change in their character and how they act, the doctor will say, why don't you get a UA and let's see how they're doing, and oftentimes they have a urinary tract infection. Asymptomatic bacteria, this is a colonization of bacteria in the bladder, and we screen and test for that during pregnancy. So how else do we diagnose? So initially we're going to dipstick for nitrates, white blood cells, and leukocytes, and to see if those things are just in the, that's easy. And then we would get a urine culture and sensitivity to see how to treat it. We're going to look at the history. For recurring UTIs, do they have more than 2 to 3 a year? Are they complicated? What about a CAUTI? And a UTI unresponsive to therapy. So for imaging, we might do an ultrasound or CT scan if it's really bad. Normally, we just do a culture and sensitivity, decide which antibiotics to give, we give it, and everyone goes on with their life. But sometimes they're more troublesome. So for diagnosis, we're going to look at the history and physical, the UA, the culture, and then imaging if there is imaging. So the management, if it's uncomplicated, would be patient teaching, remind that they need to drink a lot of fluids, go to the bathroom when you feel like you need to go to the bathroom, urinate after you have sex. So there's a lot of different things that, make sure you wipe correctly. So the drug therapy, phenazopyridine, I can never say that, and antibiotics for about 3 days. Remember to warn people that their urine will turn orange. It can stain their underwear, so be careful with that. But it does help numb, and it's a miracle drug. So for recurrent, same thing. We're going to do the same thing, but the antibiotics are going to be 7 to 14 days or longer. Super important that people finish their antibiotics. So drug therapy. So for an uncomplicated or initial UTI, we're going to use Bactrim. We're going to use cephalexin, fosfomycin. Other ones would be ampicillin, amoxicillin, or cephalosporins. You see sometimes in hospitals, it's like it goes in waves. It's like everybody's getting treated with Cipro, then everybody's getting treated with Bactrim. It's just the way it is. Complicated, especially if they see that there's a common bug. Like let's say you're constantly ordering Bactrim, but the culture and sensitivity comes back Cipro. We're just going to start prescribing Cipro first, and because typically you do the culture, you send off for the culture and sensitivity, and you order the drug. You don't wait for it to get back to order a drug and torture people. So you guess. And so if your guess always ends up wrong and it's another drug, you might want to prescribe that other drug. So if it's fungal, they're going to have fluconazole, and then that azo dye, which is that urinary analgesic that I'm talking about, that can change the urine color to orange. It can actually stain the toilet. It can stain your clothes, all sorts of things. What else makes you feel better? So we're going to ask patients about their health history, their medication, surgery, functional health patterns. And to manage, for the nursing diagnosis, it might be impaired urinary system function, acute pain, lack of knowledge, and we want people to have relief from their symptoms and no upper urinary tract involvement. We don't want it to go into their kidneys, and we don't want a recurrence. So for health promotion, we're going to recognize at-risk patients. We're going to teach them to empty their bladder regularly, evaluate their bowel, wipe front to back, adequate fluid, hospitalized patients routine, and thorough perineal hygiene. To prevent a CAUTI, we're going to avoid unnecessary catheterizations. We're going to have early removal of indwelling catheters using aseptic technique, good hand hygiene, gloves for catheter care. Make sure we do all those things. For patients, they need adequate fluid to dilute the urine and reduce the irritation. A heating pad to the lower back and the suprapubic area, or warm shower or bath. Although you got to be careful with the bath, because you'll see sometimes people that take baths too often get urinary tract infection because they don't pee after. And so they're bathing, they use soap, and there's dirt in the bath water, and then that gets in the urinary tract and they don't pee after to wash it away. And so, a little iffy on the bath. Patient teaching, we want to make sure that they complete the entire prescription and tell them what to look for. So ambulatory care, we're going to want them to make sure they take their medications, drink lots of fluids, void regularly before and after intercourse, stop using a diaphragm temporarily, and make sure you follow up if it's not better, because you don't want it to go to your kidneys. Acute pyelonephritis. So what is that? It's the inflammation of renal parenchyma and the collecting system. Most common from E. coli, Klebsiella, Enterobacter from intestinal tract. It also could be a fungi, protozoa, or virus. Urosepsis is a systemic infection from a urologic source. So pyelonephritis, the initial colonization and infection of the lower urinary tract from the urethra. So the pre-existing factor could be vesicoureteral reflux, where the upper moves from the lower to the upper urinary tract, or dysfunction of the lower urinary tract, like with a stone, obstruction, things like that. CAUTI could be long-term care residents. They might have pregnancy-induced changes. This pyelonephritis starts in the renal medulla and spreads to the cortex. So what's it going to look like if somebody has pyelonephritis? They're going to have fever, chills, nausea, vomiting, malaise, flank pain, difficulty urinating, urgency, frequency, and they're going to have tenderness over that costovertebral angle. This is what can happen if someone doesn't treat a UTI, they get pyelonephritis. So how are we going to diagnose? We're going to do a urinalysis. We're going to look at culture and sensitivity, blood cultures. Might see decreased kidney function tests. We might need an ultrasound or a CAT scan. So interprofessional, if they have mild symptoms, it's going to be outpatient or a very short inpatient, where we're going to give them fluids, NSAIDs, some follow-up cultures and imaging. The antibiotics might be 7 to 14 days. IV to oral, 14 to 21 days, and it's guided, of course, by the sensitivity. Severe symptoms will be IV fluids until orals can be tolerated because the nausea and vomiting is so bad. combination parenteral antibiotics. So this is a very serious problem. That's why we have to make sure that people get treated. Here's one of my beefs. So, with so many drugs going over the counter, it didn't used to be this way. I know I'm showing my age. I'm 53. It didn't used to be this way. But for the orange, the pill that turns your pee orange, that helps the pain to go away, literally helps the pain to go away. People go buy that over the counter and take that, and they never treat their urinary tract infection with an antibiotic, and it ends up going to their kidneys and they get pyelonephritis. So it's very dangerous. Okay, on that note, you also cannot get a good urine dip if they've taken that medicine, because it makes their urine orange. So lots of problems with that. They might say, oh, I had some of those orange pills left over from my last UTI, so I started that, before they go to the doctor. That you can't get a good dip on that. Severe symptoms, IVs, relapse. They're going to get 6 weeks of antibiotics. If it's recurrent, some people take, I have a friend who gets terrible UTIs. She takes Bactrim every single day. So, urosepsis, we're going to monitor for and treat for septic shock to prevent irreversible damage or death. For our assessment, we're going to look at past medical history, medication, surgery, functional health problems. And then objectively, we're going to look at general data, urinary, specific problems, and then possible diagnostic findings. For chronic pyelonephritis, this is where the kidneys get inflamed. It causes scarring, leading to loss of renal function. It's a big deal. That's why you really have to educate people about what not to take over the counter. This results from an anatomic abnormality or recurrent infections of the upper urinary tract. The way that we're going to diagnose this is with radiologic imaging and biopsy. The treatment is to treat the infection and the underlying factors, because we want to prevent progression to end-stage renal disease where they end up on dialysis. Urethritis, and so this is inflammation of the urethra from bacteria or virus. So trichomonas, chlamydia, gonorrhea. So obviously this happens a lot with sexually transmitted diseases. Males will have discharge, dysuria, urgency, and frequency. Females, it's hard to diagnose because it's sort of the same symptoms as having a UTI, but the treatment is antimicrobials and sitz baths. Patient teaching: avoid vaginal sprays, good perineal hygiene, no sex for 7 days, and you have to let your partners know so they can be treated too. Urethrodyverticula. You never want anything that's a diverticula, because that means that it's going somewhere where it shouldn't. So this is where there's an outpouching of the urethra from an enlarged periurethral glands. So this happens in women more than men, from trauma, from instrumentation or dilation, from a vaginal delivery, or frequent infections. So they'll present with, the cues will be difficulty urinating, post-void dribbling, frequency urgency, suprapubic discomfort, incomplete bladder emptying, incontinence, or in women it also could be asymptomatic, but they could have hematuria, cloudy urine, a vaginal wall mass with purulent drainage. So all sorts of things. And how are we going to see if they have this? An ultrasound and an MRI. We're going to do a VCUG, a urothroscopy. For surgery, we'll do a transvaginal diverticulectomy or a Spence procedure, a urethrostopic surgical excision. Complications, they can end up with incontinence, infection, bleeding, or even a fistula. So interstitial cystitis, this is a huge problem. It could be called, it's called both, IC or PBS. And so interstitial cystitis is chronic painful inflammatory disease of the bladder, which causes a painful bladder syndrome. So the inflammation is what causes the syndrome. These people have urgency, frequency, bladder, pelvic pain. It's not attributed to another cause. So you're not going to see an infection. It just hurts. It could be neurogenic hypersensitivity. There could be mast cell changes in the muscle or the mucosal layer. Could be from an infection of an unusual organism or a toxic substance in the urine. Primary clinical manifestations are pain, and it just bothers them. So if it's severe, they can void more than 60 times day or night because they always feel like they have to go. It's like always stimulating them to have to pee. The pain is usually suprapubic but may involve perineal areas. There's increased pain with bladder filling, postponed urination, physical exertion, suprapubic pressure, certain foods, or emotional distress. There's decreased pain with voiding, but it only lasts a little bit. It's often misdiagnosed as a chronic or recurrent UTI or chronic prostatitis in men, and it ends up with a diagnosis of exclusion. Okay, we've ruled out everything else, I guess you have this. And there can be remissions and exacerbations. So the treatments, it can be nutritional and drug therapy. So we don't want them to have coffee and orange juice, which are irritants. They can go over the counter and get calcium glycorophosphate, which reduces the irritation. They can use stress management strategies. Sometimes tricyclic antidepressants, analgesics, and antihistamines will help. Physical therapy, bladder hypodistension, Botox, cephalosporin A, and then surgery if they really have debilitating pain. To manage it, we got to manage their pain, look at their dietary and their lifestyle, keep a bladder and voiding log for 3 days with the pain record, monitor for a UTI with diagnostics, monitor their nutrition, have them avoid restrictive clothing, coping strategies, and then call the doctor for increased pain. Okay, now let's talk about immunologic disorders of the kidneys. So glomerulonephritis is inflammation of the glomeruli. It also is tubular and interstitial changes, vascular scarring, and hardening, and it affects both kidneys. This is the third leading cause of end-stage renal disease in the United States. The associated conditions are kidney infection, nephrotoxic drugs, immune disorders, and systemic diseases. Acutely, people have sudden symptoms which are temporary or reversible. Chronically, it'll be slow, progressive, irreversible renal failure. So acute post-streptococcal glomerulonephritis. Now this is a problem when people do not treat strep. You know, there's a lot of talk about if you get strep throat, it can affect your heart. It also can affect your kidneys. It's really important that people treat strep. So even if you're someone who doesn't like to take an antibiotic, I don't like to take antibiotics unless I need them, just because I've worked in an ICU where I saw all the resistance. But strep is something I treat. A UTI is something I treat. If it's something where if you don't treat it, it's going to hurt your vital organs, you need to do it. So this can happen in children, young adults, and adults more than 60. So it typically develops 1 to 2 weeks after an infection of the tonsils, pharynx, or skin by nephrotoxic strains of group A, B hemolytic streptococci from the antibodies to the streptococcal antigen. The exact mechanism is unknown. So what will it look like? People will have generalized edema, hypertension, oliguria, hematuria, varying degrees of proteinuria, and fluid retention. So you'll see they'll actually have weight gain. There might be periorbital edema first that progresses to total body, including ascites and peripheral edema. Very scary. Smoky urine, bleeding in the upper urinary tract. Proteinuria varies. Hypertension because of the increased extracellular fluid volume, abdominal or flank pain. It might be asymptomatic, it might just be found on a routine urinalysis. We're going to do a history and physical. We're going to do titers, decreased complement components. We might do a renal biopsy to confirm, a dipstick urinalysis and urine sediment microscopy to look for erythrocytes and protein, and a BUN and serum creatinine to see if there's been any actual renal impairment. So 95% recover completely or improve. It's important to recognize that to make sure it doesn't progress to chronic glomerulonephritis. So we want to make sure they have symptom relief. People need to rest, decrease their inflammation and their hypertension, reduce and restrict their sodium and fluids, and give them diuretics to get rid of that edema, restrict their protein. We want to decrease their BUN. And then if they still have streptococcal infection, we're going to want to give antibiotics to treat that infection. So to prevent it, we want to early diagnose and treat sore throats and skin lesions. If there's a positive streptococci culture, we need antibiotics, take the entire prescription, and then make sure that a good personal hygiene with skin infections. If it's chronic, so this is a syndrome of permanent and progressive renal fibrosis that can lead to end-stage renal disease. No history of renal disease, and it's like the Alport syndrome, which is inherited. The symptoms develop slowly. People can be completely unaware. It can be found coincidentally with an abnormal UA, with increased blood pressure, or increased serum creatinine. See, a lot of people think that hypertension is always from the heart, and it's not. It's often from the kidneys. We might have decreased renal function that causes end-stage renal disease when it happens over several years. So how does this manifest? We'll see hematuria, proteinuria, urinary excretion of red blood cells, white blood cells, increased BUN and creatinine. For diagnosis, we're going to look at their history and physical, their exposure to NSAIDs, because, NSAIDs are not candy and they're not good for your kidneys. Microbial infections and viral infections. I say that because people think that if they take something over the counter that it's not a big deal. And as we've discussed, it's a huge deal. Let's see, you could take Tylenol and kill your liver. You could take Motrin and kill your kidneys. You can take those little orange pills and not know you have a raging kidney infection. You can take Tums and put yourself into metabolic alkalosis. So this is why people need nurses, to educate them. Anyway, I digress. So we're going to look for exposure to drugs, microbial infection, viral infection. We're going to evaluate for immune disorders, do an ultrasound, CT, and renal biopsy. We're going to treat the symptoms and, of course, give them supportive care. So Goodpasture syndrome. This is an autoimmune disease where antibodies attack the glomerular and basement membranes. So the kidney and lung damage from antibody binding causes inflammatory reaction and complement activation. It is a rare disease. It occurs ages 30s to 60s. It looks like flu and pulmonary symptoms, but there's renal involvement. You don't expect to have a cold and have your kidneys involved. So that's what's unusual about it. The management is steroids, immunosuppressive drugs, plasmapheresis, rituximab, dialysis, and a renal transplant. For nursing, have people quit smoking. Critical care. As for AKI and respiratory distress, it can be fatal from hemorrhage and respiratory failure. So many things are caused from smoking. If you smoke, I hope you quit. RPGN. So this is glomerular disease with crescent formation, so loss of renal function in days to weeks. This occurs when there is a complication of inflammatory or infectious disease, a complication of systemic disease, or it's idiopathic. It manifests itself, what are our cues? Hypertension, edema, proteinuria, hematuria, red blood cells, casts. We're going to correct their fluid overload, correct their hypertension, the uremia, and the injury to the kidney with corticosteroids, with cyclophosphamide, which is a chemotherapeutic drug, plasmapheresis, and then dialysis and transplant. Nephrotic syndrome. So glomerulus that's permeable to plasma protein, causing the proteinuria, leading to low albumin and edema. So if you lose all your protein out your urine, you're not going to have enough protein, and your albumin's going to be low. So on assessment, you might see weight gain. So if someone has nephrotic syndrome, they might have weight gain because of the edema. So the etiology and clinical manifestations, look in the book. 1/3 of them have systemic disease, but could be peripheral edema, massive proteinuria, hypertension, hyperlipidemia, hypoalbuminemia, foamy urine. So they have decreased albumin, ascites, anasarca when it's severe. Hypoalbuminemia is present. Immune response is altered that results in infection, hypocalcemia and skeletal abnormalities, and hypercoagulability. So what are we going to do? So the treatment depends on the cause. We're going to treat the cause. Our goals are to cure or control the primary disease and relieve their symptoms with corticosteroids, cyclophosphamide. We're going to manage their diabetes if it's from diabetes. They might need an ACE inhibitor, an ARB, diuretics, anti-hyperlipidemic drugs, anticoagulants. For their diet, low sodium, moderate protein, small frequent meals. We're going to manage their edema, do their daily weights, accurate eyes and nose, and measure their abdomen or extremities to see if the edema is going down, and really try to avoid infection. Okay, obstructive uropathies. So this is where there's an obstruction somewhere in the urinary canal. So a urinary obstruction is an anatomic or functional condition that blocks or impedes the flow of urine. That's a pretty simple definition, right? Okay, it can be congenital, meaning you were born with it, or acquired. You ended up with it after you were born. The damage occurs above the level of obstruction. It may affect only one kidney, and the other kidney might compensate. Like, uh-oh, look what's going on over here. We better do a better job on our end. So in the bladder, neck, or the prostate in men, the detrusor muscle has hypertrophy, and eventually there's large residual urine. In the bladder outlet, there might be increased pressure with filling or storage. So you could have a partial obstruction of the ureter or ureteropelvic junction, UPJ. So this would be like low to moderate pressure. Kidney dilates without a noticeable loss of function, just sort of, it's compensating, it's dilating to see what it can do. There's urinary stasis and reflux, which increases the risk of pyelonephritis. You do not want urine just hanging out, because urine needs to exit. If it hangs out, it grows bacteria, and you have all sorts of problems. So both kidneys or only one functioning kidney involved means we have a change in renal function occurs and the BUN and creatinine increase. And then we have progressive obstruction that can lead to renal failure. So the treatment, we're going to find and relieve the blockage. That's easy, right? Insert a tube, surgery, or urinary diversion, and then you just have to hope that everything goes back to normal and help people get back to normal after you relieve that blockage. So urinary tract calculi, or kidney stones, that's the fancy word is urinary tract calculi, nephrolithasis, but kidney stone disease is what we're going to call it. In the United States, 13% of men and 7% of women. The risk increases with age. It's more frequent in whites than blacks, Hispanics, and Asians. Those with a family history have a higher incidence. So Southeast United States is the most common, followed by Southwest and then the Midwest. So summer, where it's hot climate and dehydration, it's the worst because there's just not enough fluids because people are dehydrated. And then uric acid stones in Jewish men. It's common. I almost said it's popular. Popular is a bad word because that has a good connotation. We're going to say it's common. Okay, why do people get kidney stones? Metabolic, the climate, dietary, genetic, or lifestyle. So it is a concentration. So what is this? A stone is actually a concentration of supersaturated crystals that precipitate and form a stone. So how do you reduce the risk? By keeping your urine going. Drink, 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 and free flowing. So the stone formation, the influencing factors. So we look at the urinary pH. A higher pH, calcium and phosphate is less soluble. Lower pH, uric acid and cysteine is less soluble. We look at the solute load, the inhibitors in the urine, obstruction with urinary stasis, infection with urea splitting bacteria, infected stones, where we might end up with a renal infection, hydronephrosis, loss of kidney function. So there are 5 types of stone: calcium oxalate, calcium phosphate, cysteine, struvite, and uric acid. Calcium stones are the most common, and they may be mixed or in various locations. The first symptom is going to be sudden severe pain, like in their back. Terrible, horrible pain, their flank area, their back or lower abdomen. The ureter stretches, dilates, and spasms. That hurts. Causes nausea and vomiting. People do like a kidney stone dance. It's like you can't sit still. It hurts so much. Dysuria, fever, chills, moist, cool skin. The common sites of obstruction would be the ureteropelvic junction, which would cause dull costovertebral flank pain or renal colic, or the uterovesical junction, which would cause lower abdominal pain and testicular or labial pain. How are we going to see what's going on? Do a CT scan, ultrasound, urinalysis, and a 24-hour urine. We want to retrieve and analyze those stones because we want to determine the problem. Because once you know what the stone is made of, you know what to avoid or how to treat it. How do we do it? We're going to manage that acute attack. It is extremely painful. Some people say that it's similar to childbirth if you pass a stone. Pain, infection, obstruction, we're going to give them opioids, NSAIDs, alpha-adrenergic blockers. We're going to look at the cause of the stone formation to prevent further development. So we're going to look at family history, nutrition, fluids, vitamins, activity. Is there history of a prolonged illness, GI or GU disease or surgery? Previous stones, OTC meds that are prescribed or not, and dietary supplements. So we're going to want to make sure people hydrate adequately, watch their sodium, dietary changes, look at the drugs they're using. And for struvite stones, we're going to look at antibiotics and acetyl hydroxamic acid, and then surgery. Interprofessionally, so stones of 4 millimeters or less may pass spontaneously and may take weeks and hurt. Or we're going to have surgery if they're too large. And so if it's too large, more than 7 millimeters, it can't pass spontaneously. So that will be associated with bacteria or symptomatic infection. It's going to impair the kidneys. It can cause persistent pain, nausea, or paralytic ileus, or the patient can't be treated medically or only has one kidney. So what are we going to do? A cystoscopy is where we remove the stone in the bladder. Cystolitholipaxy, large stone broken up with lithotrite, which is a stone crusher. That sounds fun. No, not fun. Cystoscopic lithotripsy, which is an ultrasonic waves that break up the stones. That's common. And the complications of the above procedures, people could hemorrhage. They could have a retained stone fragment that doesn't pass out. Not that the stone passes out, that doesn't pass out the urine. Or they could have infection. Just trying to make sure you guys are awake. Okay. They could also have an ultrasonic laser or electrohydraulic lithotripsy used to break up those stones. So this is where they remove the stones from the renal pelvis and upper urinary tract. They could have a percutaneous nephrolithotomy. So a nephroscope is inserted through the skin into the pelvis of the kidney. The stone fragments are removed, followed by irrigation, and they might have a nephrostomy tube in there. Complications: bleeding, injury to the adjacent structures, and infection. So this lithotripsy, it eliminates stones, so it's laser or ESWL or percutaneous or electrohydraulic. So all different ones. Electrohydraulic, they would have a urethral stent placed to facilitate passage of the stone, removed in 2 weeks. Post-procedure, they could have hematuria. Prophylactic antibiotics are going to be given. We're going to encourage fluid to dilute the urine and reduce pain. Rare complications include hemorrhage, infection, and obstruction. Surgery. If they have pain, infection, and obstruction, they could need a nephrolithotomy of the kidney, pyelolithotomy of the renal pelvis, ureterolithotomy of the ureter, or cystotomy of the bladder. Post-op complications would be hemorrhage. So for nutrition, if there's an obstructing stone, they need fluids to avoid dehydration. Forcing fluids is not recommended because they have increased pain, but they need to drink enough. After urolithiasis, we need about 3 liters of fluid a day. So if someone has a kidney stone, they need to have about 3 liters of fluid a day, because that will give them about 2.5 liters of urine a day. Water is best. Prevent supersaturation of the minerals, reduce risk of dehydration, limit colas, coffee, and tea because they increase stone formation, a low sodium diet, dietary restrictions according to the type of stone, which would be taurine, calcium, and oxalate. So like there's different, if you look up an oxalate-free diet, there's a whole diet that people need to go on if they have kidney stones. Lifestyle changes, diet changes that we talked about, immobile bed rest patients, and then there's different medications and patient teaching, which is in your book. Ureteral strictures, and so this can affect the entire length of the ureter and alter kidney function. So it could be congenital, it could be an adhesion or a scar, or a large tumor in the peritoneal cavity that presses up against the ureter, causing it to, if you have a tumor, then it doesn't open up. The clinical manifestations, they'll have mild to moderate pain, flank pain. Treatments, we're going to bypass with if you can't use the ureter, you need something. The urine has to get from the kidney to the bladder. So we're going to bypass with a stent or a nephrostomy tube placement, balloon, or catheter dilation. Just like you balloon other places, like in the heart, you can balloon the ureter. So all these different surgeries they might need as well. So fibrosis or inflammation of the urethral lumen leads to narrowing and compromised opening and closing with bladder filling and voiding. This could be from trauma, from urethritis, from a surgical intervention, or repeated catheterizations, or it could be a congenital defect or idiopathic. We have no idea. So they're straining to void. The urine stream is diminished, sprayed, or split. Think about like when you have a water hose and, there's nothing constricting the water hose, it just comes out. But let's say you put your thumb over that water hose, and now it's like the water comes out funny. That's how this is. It could spray or split off because there's something there that's not supposed to be. So they could have incomplete bladder emptying frequency, nocturia. Severe obstruction will be urinary retention because the urine isn't going anywhere. How are we going to diagnose this? With a retrograde urethropography. an ultrasound, a cystourethrogram, and a VCUG. The treatment, we're going to dilate it with a metal instrument or stents. Stenosis may occur. They might need to self-catheterize every few days, or they might have an endoscopic or surgical procedure. Renal trauma. So this would be a trauma, right? You get hit in your back, in the kidney area. So a blunt trauma is the most common. It causes abdominal, flank, or back injury. It could be a sport injury. It could be a motor vehicle accident, a fall. Penetrating could be gunshot, stabbing into your kidney. The clinical manifestations is going to be blood in your urine. We're going to look at a urinalysis, an ultrasound, a CT, MRI, and renal arteriogram. So the treatment depends on the severity. Bed rest, fluids, analgesia. We might need to do an exploratory surgery and repair. We might have to do a nephrectomy. Nursing care. We're going to assess cardiovascular status and monitor for shock. We're going to look at their INO, pain, monitor for blood in the urine, and myoglobinuria. Renal vascular problems. So renal artery stenosis, very common. You probably see that in patient charts all the time. So it's a partial occlusion of one or both renal arteries and major branches. It is caused by atherosclerosis or fibromuscular hyperplasia. It manifests as sudden hypertension. We're going to do a renal Doppler, ultrasound, CT, MRI. The treatment goal, we need to control their blood pressure and restore perfusion. The treatment will be percutaneous transluminal renal angioplasty or a surgical revascularization or a nephrectomy if one kidney is involved. Renal vein thrombosis. We never want a thrombosis, which is a clot. It can be unilateral, it can be bilateral, it could be caused from trauma, from extrinsic compression, renal cell cancer, pregnancy, contraceptive use, nephrotic syndrome. Manifestations would be flank pain, hematuria, or nephrotic syndrome. We're going to treat with anticoagulants, corticosteroids, and possibly surgical thrombectomy. What about hereditary kidney disease? So that's where you didn't do anything to cause it. It's hereditary, cystic in nature, and we always want to rule out other causes or tumors. Nephrosclerosis. It's a sclerosis of those small arteries and arterioles of the kidney, causing reduced blood flow, ischemia, interstitial fibrosis, and necrosis. So it could be benign, which is age-related, which more than 60 years old just get sclerosis because people have hypertension, primarily. Accelerated, like malignant nephrosclerosis, is a medical emergency due to severe hypertension, where the systolic is more than 180 and the diastolic is greater or equal to 120. We treat this with antihypertensive medications. Polycystic kidney disease. This is one of the most life-threatening genetic diseases in the world. In the United States, more than 600,000 people. It's the fourth leading cause of end-stage renal disease. It's genetic. So there are two hereditary forms. So adult, there's an autosomal dominant, and then in child, it's an autosomal recessive. Adult PKD affects both kidneys in men and women. The cortex and medulla filled with thin wall cysts that destroy the surrounding tissue. These cysts are filled with fluid. They may have blood. They may have pus. Symptoms usually develop at 30 to 40 years of age. Clinical manifestations initially would be hypertension, hematuria, pain, or a heavy feeling in the back, side, or abdomen. UTI or urinary stones might be asymptomatic. The most common is chronic severe pain. So the kidneys are enlarged. You might feel the kidneys, which is very unusual. It affects the liver, heart, blood vessels, intestines, and brain. They're going to need an ultrasound or a CT scan. Look at their family history. There is no cure. We need to prevent and treat UTIs, possibly a nephrectomy, possibly dialysis and a kidney transplant. We're going to do genetic counseling. Medullary cystic disease is a hereditary disorder of older adults. Kidneys with cysts in the medulla are asymmetric and scarred, and they can't concentrate urine. So they'll have polyuria, hypertension, progressive renal failure, severe anemia, and metabolic acidosis. The treatment is the same as end-stage renal disease, and we need genetic counseling. Alport syndrome. This is a chronic hereditary nephritis. Males earlier and more severe than females. The gene mutation for collagen resulting in altered synthesis of the glomerular basement membrane. There are 3 genetic types. The sex-linked is the most common. They could have hematuria, progressive hearing loss, and deformity in their lens. Autosomal recessive and autosomal dominant, they're going to have hematuria. The treatment is management of end-stage renal disease, such as a kidney transplant. Urinary tract tumors. So kidney cancer. In the United States, 63,342 new cases a year, 14,970 die. Renal cell carcinoma or adenocarcinoma is the most common. Males more than females. The average age is 64. The risk factors are cigarette smoking, ACKD, obesity, hypertension, exposure to asbestos, cadmium, and gasoline. Increased incidence if there's a first-degree relative that also has kidney cancer. In the early stage, it'll be asymptomatic, often incidental finding when they do a scan and like, oh, we see a tumor on your kidney. That's what happens a lot. 25% are metastatic when they're diagnosed to the renal vein, to the vena cava, lungs, liver, and long bones. The common manifestations are hematuria, flank pain, a palpable mass in the flank or abdomen. Other common manifestations would be weight loss, fever, hypertension, and anemia. We'll, for diagnosis, we're going to do a scan, CT scan, ultrasound, angiography. We're going to biopsy, get an MRI, and possibly a radionuclide isotope scan. We want to encourage people to stop smoking, keep their weight under control, to control their blood pressure, avoid exposure to toxins, identify high-risk groups, and patient teaching about early manifestations. It's going to be staged. We want early detection for a higher chance for cure. So people need to report their symptoms. Surgery would be a nephrectomy, either partial, simple, total, or radical, open or laparoscopic. There could be an ablation, could be immunotherapy, targeted therapy with kinase inhibitors, so all sorts of things. It is bladder cancer. It is the most common urinary system cancer. 81,000 new cases a year, 17,000 deaths. More older adults, older than 55 accounts for 90% of the cases. Men more than women, whites more than blacks or Hispanics. So transitional cell cancer is the most common. Most are papillomatous growths. The risk factor is cigarette smoking. Other is industrial exposure to dyes, cervical cancer treated with radiation or chemotherapy, prolonged indwelling catheters, chronic recurrent urinary tract stones, and chronic UTIs. The most common manifestations are microscopic or gross painless hematuria. Others is dysuria, frequency, and urgency. For diagnostics, we're going to look at urine specimens for cancer or atypical cells and bladder tumor antigens. We're going to do scans. We're going to do a cystoscopy and biopsy to confirm cancer. The cancer is graded and staged 1 to 5 before treatment. Most are diagnosed early. The stage is determined by the depth of invasion of the bladder and surrounding tissue. The treatments will be surgery, radiation, chemo, or intravesical therapy. For surgery, they might have a transurethral resection of the bladder tumor, superficial lesions removed with a cystoscope. So fulguration, that's where it burns the base of the tumor, or high energy laser, which kills the cancer cells. This is used to control the bleeding in people that have advanced tumors. The problem is they could have recurrence, scarring, or the inability to hold their urine. Segmental or a partial cystectomy was where you remove large tumors in one area of the bladder wall and the margin of the normal tissue. So a radical cystectomy is for an invasive tumor or trigone area, but no metastasis beyond the pelvic area, and they must have a urinary diversion. So that's always a problem, is having the urinary diversion. Postoperatively, drink lots of fluids for 1 week. Patient teaching, we're going to monitor the color and the consistency of the urine. It's going to be pink for several days. If they have clots, they need to report that to the surgeon. It's not normal. They might have dark red or rust color flecks for 7 to 10 days, but no clots. They're going to have opioid, analgesics, and stool softeners to make sure that they don't get constipated. For radiation therapy, primary therapy, or in combination with cystectomy, they're going to have chemo and immunotherapy. Intravesical therapy is where a local installation of immunotherapy or chemotherapy by urethral catheter. So that's where, instead of putting the chemotherapy in your vein in an IV, they put it in the catheter right into your bladder. They retain it for 2 hours, and then they change the position every 15 minutes. And so I used to be an oncology nurse and give chemotherapy, so this was sort of cool. So they would be in bed. You would, sort of do the opposite, where instead of the catheter having to come out, you put the chemotherapy it goes into the bladder. You have them move every 15 minutes because you want that, you don't fill up the bladder completely, and you want the chemotherapy to touch every spot on that bladder, and then you take it out. They do it weekly for 6 to 12 weeks. Post-procedure, it could hurt when they urinate, and they could have hemorrhagic cystitis, and so we want to make sure they increase their fluids. Bladder dysfunction. So urinary incontinence, very common, more prevalent with older adults, women more than men because of childbearing, but not a natural consequence of aging. The gender differences, men, it's common with BPH or prostate cancer, women from stress or urge incontinence. The bladder pressure is greater than urethral closure pressure, and so drip. So this is the DRIP, delirium, dehydration, depression, restricted mobility, rectal impaction, infection, inflammation, impaction, polyuria, and polypharmacy. So drip are the things that can cause urinary incontinence. The types, you could have stress combined, which urgent incontinence, mixed or incontinence, overflow, reflex, after trauma, functional incontinence, or they might have more than one type. For diagnostics, they're going to want to keep a bladder log or a voiding record. When it starts, what are the associated conditions? What did you have to drink? Have you had anything to drink? Things like that. Physical exam, we're going to want to look at their general health, their pelvic exam. We're going to look at a urinalysis, post-void residuals, urodynamic studies, and an ultrasound. Many can be cured or improved. The intervention depends on the type. So we're going to do lifestyle modifications, a schedule for voiding, pelvic floor muscle rehab, anti-incontinence devices, and containment devices. We might give drugs, surgery, depending on the type. They might need urinary structural support or repositioning, retropubic copal suspension and pubovaginal sling, suburethral sling, bulking agent injection, or an artificial sphincter surgery. So we're going to identify the physical and emotional concern. We want to maintain their dignity, privacy, and self-worth. So we're going to use containment devices for leakage, and then we're going to plan to reduce or resolve the factors. So if you look in your book, you'll see all the lifestyle modifications, behavioral treatments, and products to contain urine. So urinary retention, unlike urinary incontinence, is where you don't want to get rid of your urine. It's the inability to empty the bladder with voiding, or the accumulation of urine because you can't void. It could be associated with leakage or post-void dribbling because there's overflow in urinary incontinence. Acute urinary retention is the inability to pass urine. It's a medical emergency. Chronic urinary retention is incomplete emptying despite urination. So post-void residuals will be normal is 50 to 75, but these people have more than 100 or more than 200. Bladder outlet obstruction is where the bladder can't empty because there's a blockage, like men, if there's a big prostate, can't get around. Or a deficient detrusor contraction, the muscle can't contract with enough force to empty the bladder. So neurological diseases involving the sacral 2, 3, and 4, diabetes, overdistension, chronic alcohol use, or anticholinergic drugs. So diagnosis, we're going to do a urinalysis, post-void residual, urodynamic studies, or an ultrasound. Interprofessional care, we're going to do behavioral therapies, scheduled toileting, catheterization, either intermittent or indwelling, and drug therapy. For surgery, they might need a transurethral or open technique for a prostate enlargement, bladder neck contracture, urethral strictures, a bladder neck. They might have pelvic organ prolapse. For surgical therapy, they might have a sacral neuromodulation or intraurethral valvular pump. For acute urinary retention, if it's an emergency, they can't get it out, we're going to put a catheter in. Hopefully you can get a catheter in. Consider an indwelling catheter to help them get rid of this retention. Patient teaching to minimize the risk is to drink small amounts throughout the day and to be warm when trying to avoid excess alcohol. They could drink caffeinated coffee or tea to increase their urine. They could take a warm bath or shower or seek medical care. For chronic, they're going to need a behavioral schedule with toileting, catheterization, surgery, or drugs. So catheterization. Why do we need an indwelling catheter? To relieve urinary retention, for bladder decompression pre-op or post-op, to facilitate surgery, to facilitate healing, if we need accurate INOs in critical care, for a stage 3 or 4 pressure ulcer, or a terminal illness for comfort. For an intermittent, maybe to relieve urinary retention, diagnostics, urodynamic testing, a sterile specimen, medication installation, or to measure PVR. Unacceptable reasons would be a routine urine specimen or for convenience for the nurse or the family. Complications of long-term use more than 30 days, a CAUTI most commonly. Other, they could have bladder spasms, an abscess, chronic pyelonephritis, urosepsis, urethral trauma, erosion, fistula, stricture formation, and stones. Sorry, wrong. I did that twice. Catheter construction. So it is made of Teflon coated latex. Okay, make sure if people have a latex allergy, you do not use a latex catheter, or you will see labia the size of your leg. Terrible. I've heard about this a couple times where people's labia are so huge because they have a catheter because they're allergic to latex and somebody put in a catheter. It's a nightmare. So make sure of that. Hopefully you never forget that. Look at the tip shape, the lumen size. Women typically need 14 to 16, men 14 to 18. The balloon capacity is either 5 mil to 30 mil. Make sure you look because you don't want to bust the balloon when you put in too much fluid. Tissue erosion can occur if the catheter is too large. To prevent a CAUTI, make sure there's a need for a catheter. Choose the appropriate size and type. Insert patient with urethral trauma, pain, or obstruction. Develop a plan of care to decrease the risk of infection, which is usually cleaning and making sure it stays patent with lots of fluids. Teach catheter care to the patient, especially if they're ambulatory. Use a closed system and do not disconnect except for irrigation. Use sterile technique if it's an open system. Consider triple lumen catheter for continuous irrigations. If it's not necessary, less than 2 weeks for long-term, determine necessity based on assessment. Use the catheter sampling port for urine cultures and prepare the puncture site with antiseptic solution. We're going to use a leg bag for long-term catheter use, and if you're reusing the collection bag, it needs to be cleaned thoroughly. Remove the catheter as early as possible. If there's intermittent catheterization or external catheters, there's less chances of a CAUTI. Make sure the unlicensed assisted personnel maintain unobstructed downflow flow of urine. Make sure that bag is lower than the person. Empty it regularly. Provide perineal care 1 to 2 times a day. Do not use lotion or powder near the catheter, and use a securement device to prevent the catheter movement and tension. So it's placed through the ureter into the renal pelvis by threading up the urethra and bladder with a cystoscopy. This would be a ureteral catheter, different than the type that we put in the bladder. Surgical insertion through the abdominal wall. Use post-op to prevent obstruction by edema, so we're going to want to record the output. Bed rest, check the placement, avoid tension. Use aseptic technique and monitor the output. Suprapubic catheters, this is a form of a urinary diversion and it might be temporary. And look in your book, there's a lot of good pictures. The insertion is either through the abdominal wall, they need general anesthesia, or local. It may be sutured, taped to prevent dislodgement. You want to use care and skin barrier because you don't want their skin getting hurt. Ensure the patency, prevent kinking, milk the tube, whatever you need to do to make sure it's okay. They can get bladder spasms, so watch for that. Nephrostomy tubes. So this is a temporary insertion through the small flank incision into the renal pelvis, and this is when the ureter is completely obstructed. We talked about this just a minute ago. We're going to avoid kinking, compression, or clamping. Check the patency. Strict aseptic technique that is going right to the kidney. Complications would be infection and secondary stone formation. So intermittent catheterization. This is like a straight cath or in and out. The main goal is to prevent retention, stasis, and compromise blood supply to the bladder from prolonged pressure. We're going to use this if a patient has a neurogenic bladder outlet obstruction in men, or post-op. The catheter is inserted every 3 to 5 hours or 1 to 2 times a day for residual urine. There are variable techniques and protocols. So single would be sterile use, or clean multiple use technique. There are coded and uncoded. It could be inserted by the patient themselves, a caregiver, or a healthcare professional. Lubrication helps with the insertion. Sterile technique. Home care is clean technique. They may need prophylactic antibiotics. The complications would be urethritis, urethral sphincter damage, urethral stricture, creation of a false passage. Okay, we are almost done. You guys hang in there. Surgery of the urinary tract. Renal and ureteral surgery. So indications for a nephrectomy would be a tumor, bleeding, infected, polycystic kidney, massive trauma, or a donor transplant. It can be open or laparoscopic. There will be a 6 to 10 inch incision in the flank or abdomen. Laparoscopically, there'll be 3 to 5 puncture sites. So the basic needs, look at chapters 17 to 19 in the book on pre-op management. We want to ensure adequate fluids and normal electrolytes, and they may have pain from their positioning in the OR. Postoperatively, we want to measure the urine. It's very important that if there is decreased urine that we notify the surgeon. We want to note the color and consistency and the catheter patency and do daily weights. Respiratory status, we want to make sure they cough and deep breathe. For abdominal distension, we're going to monitor for a paralytic ileus, check the bowel sounds, IV fluids and oral fluids when the bowel sounds return, and then progress to a regular diet. A urinary diversion, if there is urine blocked from bladder cancer, neurogenic bladder, congenital anomalies, all the things we've talked about. So there are type of surgical procedures for a urinary diversion. So an incontinent urinary diversion, it's a diversion to the skin. They must wear an appliance. The most common is an ileal conduit. The ureters are anastomosed to the conduit, and the bowel is brought to the abdominal wall to form a stoma. No valve equals no voluntary control, and the urine drips into an external collection device. An intra-abdominal urinary reservoir that can be catheterized has an internal pouch. That's what a continent urinary diversion. So there's a reservoir inside that's constructed from the ileum, the ileocecal segment, or ascending colon. So it's a surgically created valve and large low-pressure reservoir, which prevents involuntary leaking. There's no external collection device needed, and patients can self-catheterize every 4 to 6 hours. Orthotopic bladder reconstruction. So this is construction of a new bladder in correct anatomical position, and the urine is discharged through the urethra. A neobladder is surgically shaped from various segments of intestines. The candidates have to have normal renal and liver function, 1 to 2 year life expectancy, good motor skills, no inflammatory bowel disease or colon cancer, and not obese. For nursing, pre-op management, we're going to educate a lot of psychosocial support, because it's a big deal. They have a lot of anxiety and fear, and they're going to live with a stoma and be incontinent and all the things. Post-op, we want to prevent complications, atelectasis, shock, thrombophlebitis, small bowel obstruction, paralytic ileus, and a UTI. Prevent injuring the stoma and maintain urine output. For the ileal conduit, we need meticulous skin care, and we need to avoid alkaline incrustations with dermatitis and yeast infections. Change the appliances, and patient teaching how and when to catheterize. For the orthotopic bladder, we need to catheterize for post-op urinary retention. Bladder control may take up to 6 months. They're going to empty the bladder every 2 to 4 hours by relaxing that outlet sphincter and bearing down with the abdominal muscles. They do not feel the need to void. Postoperative body image, make sure you talk to them so they can share their feelings and concerns. For discharge teaching, we're going to want to teach them the symptoms of obstruction or infection, ostomy care, and then follow up with their healthcare provider. Okay, everyone, thank you so much for hanging in there with me. Have a wonderful week.